Thanks, Conrad, for recording. So welcome back, everybody. I'm so excited to get started with our guest presenter, Dr. Marshall. So Dr. Nicole Marshall is the division head and associate professor of maternal and fetal medicine at OHSU. Her areas of research and scholarly interest include maternal body composition, the impacts of metabolism and obesity on lactation, and nutrition in pregnancy and lactation. I had the pleasure of listening to Dr. Marshall present at Oregon Nutrition Day earlier this year, and I'm thrilled that she's here with us today. So welcome to Oregon WIC, Dr. Marshall, and I'll turn it over to you.
Thank you, Ellen. I am excited to be able to be here today. And as Ellen had sent a list of things to talk about, I was like, oh, so many of those things are some of my absolute favorite things to think about and to talk about, recognizing that there are so many different perspectives and so many things to bring into it. So my hope is that we can really have kind of an interactive discussion today. Unfortunately, I can't see the chat very well or folks, so please stop me at any time or catch my attention if there's things that don't make sense, because I'm hoping we can have just a fun afternoon discussion here to round out your meeting today. So let's see if this is going to let me move. So my disclosures, I was on the Academy of Breastfeeding Medicine protocol committee at the time that the mastitis spectrum protocol came out. So I was involved in the editing and some of the handouts and things. So just to know about that. And I also serve as a section editor for Up to Date. And then I volunteer with Northwest Mothers Milk Bank on the medical advisory board. But I think probably the most important thing for me to disclose is I certainly have my own biases related to my personal breastfeeding experience. I think if you had asked me, as I was going through my medical training, whether I would be doing lactation research, that would not at all have been on my radar. And it was really my personal experience and the challenges that I faced and that many of my colleagues and friends have faced, as well as my patients, that have really influenced so many of the areas that I am now passionate about trying to learn more about, so that we can better answer the questions that our patients have, that our families have, and that we recognize where we need to be really putting our attention. So I also very much want to center this in the reproductive justice framework, recognizing that the women who came up with this, early 90s, really this idea that the right to not have a child, the right to have a child, and then the right to be able to parent that child in the way that you feel is best, and that also extends to breastfeeding or chest feeding or expressing milk or however individuals are identifying with their families, and that because that is a human right, both for our infants to be able to have milk and for our patients who choose to be able to provide that milk. And what are the things that we as a society and we as professionals are able to do to really support them in that journey. And so this is one of my favorite quotes. Human milk is like ice cream, penicillin, and the drug ecstasy all wrapped up in two pretty packages. This is very much looking at what are the infant benefits of breastfeeding. So those benefits, not only for the nutrition component of it, but also the ability to fight infection, to protect health, to impact long-term health, and also for mood regulation, for bonding of parent and child, or the lactating individual and their infant. And that we know that it goes so much beyond just those relationships. But also, when we think about what are the expectations, what are the recommendations, how should we be thinking about this? That the recommendation is exclusive breastfeeding for the first 6 months. And I will fully admit that until I had children, I had never really even heard of exclusive breastfeeding or what that was or what that meant. And we are increasingly recognizing the benefits for the health of the lactating person in terms of their long-term health. So decreased risk of cardiovascular disease, stroke, obesity, type 2 diabetes, so many other factors. and that the degree of benefit is really related to the length of breastfeeding and the amount of breastfeeding that is done, at least from the very limited data that we have so far. And so recognizing that it is not only important for, I was very frustrated in the last Academy of Pediatric, their statement back in 2012, where they described breastfeeding as a lifestyle choice. I think that very much underestimates the effort and the amount of work that goes into it. But recognizing that it is important primarily to be able for folks to meet their own goals. Again, with that reproductive justice framework, if I have a patient who their intent is to mix feed, and they are able to accomplish that, great. That is a success. We have met their goals. And when I have patients who want to exclusively breastfeed and they are unable to for whatever reason, then that is an area that we need to address and that we need to be looking at how are the ways that we can better support them in that journey. So I also think it's important to be able to frame, what does it take to be able to exclusively breastfeed? And you have to be able to make enough milk to meet all of the infant's needs, first and foremost. The infant has to be able to transfer that milk effectively, so that they are able to consume that nutrition. We think on average, infants are eating about 8 to 12 times a day, and that we recommend on-demand feeding, so every 30 minutes to 3 hours, depending on if we're in the midst of a cluster feed. And so essentially that is a full-time job, and being available constantly, and recognizing that we are existing in an environment where that is not the norm, and that we don't have the resources for our lactation, our lactating individuals to be able to meet that. And the reality, Oregon paid leave is trying. So, fortunately, that is now in place, and we're seeing some differences. But for many of our patients and our clients, they're not going to be able to be with their infant all of the time, and so that means now that they're going to need to do all of this in addition to expressing or pumping milk to be able to meet that. And we are fortunate to be in a state where Oregon does have strong breastfeeding laws, and protection for individuals to be able to continue to support that. And as I tell my patients, unfortunately, no one is going to care about your ability to feed your child and to breastfeed as much as you are. And so, unfortunately, you maybe need to become an advocate for the ability to do that. And I would be remiss if I didn't talk about the significant racial the disparities that go into this as we think about, and I think this was a study that it was published back in 2021, that looked at some of the factors that influence these huge disparity rates between exclusive breastfeeding for Black mothers and white mothers. And I think, when we think about so many of those things that come together, so much of it unfortunately ties back to structural racism for the socioeconomic position, and that we see this massive gap of 50 points between Black mothers' ability to meet their goals for breastfeeding with white mothers, and that this is really incumbent upon all of us to think about how do we change the system to be able to support our families and our community to be able to meet their needs. This is another graphic that just drives me bonkers, to think about, is breastfeeding free? Is it really free? And of course, the thing that is not at all included in this is the time that it takes, and the amount of time and effort and energy that is expended to be able to feed an infant. And I found this quote on TikTok. This was from a individual who exclusively pumped for her son and kept track of all of the hours that she spent pumping and all of the milk that she produced. So 125 gallons, 2,388 hours spent pumping. Doing some quick math, if we break that into 8-hour days, that would be about a $47,000 a year. But if we go back just to the 1 year since she was over that, 273 days, which would be about 55 weeks, which, wait a minute, that's actually more than a full-time job. And of course, because there are no vacations in breastfeeding, there are no weekends or holidays or evenings off, that this really is a full-time job. And for many of my patients, they are having preterm births, very early deliveries, infants that are in the NICU. They are dealing with their own health challenges and potentially complicated deliveries, or recovering from surgery. And these are the things that we are asking of them to do every day, and recognizing that each individual has their own capacity to be able to make milk, and that that's going to be different for each individual. And that's one of the most fascinating things about breast milk. And when we think about the ability that, for many individuals, each breast has a different storage capacity. So one breast may make way more milk than the other, or they may make the exact same amount, or it may change throughout the day, and the volume that they are produced, and then the actual composition of the milk is constantly changing as well. Another quote that is now, well over 100 years old, that a pair of substantial mammary glands has the advantage over the two hemispheres of the most learned professor's brain in the art of compounding a nutritious fluid for infants. And again, this is really calling out, long before we had the ability to actually be able to look at the composition of milk, and just knowing that it is changing throughout the day per feed, the beginning of the feed to the end of the feed. And this is really the start of, personalized medicine, or personalized opportunities to start folks out on that path to optimal nutrition throughout their life. And what are the things that we can be doing to really support that? So putting kind of all of that framework together and thinking about, let's start by talking about some of the newer mastitis spectrum guidelines that came out now about a year and a half ago, and some of the changes. This is based off of the 2022 protocol that was published in the Academy of Breastfeeding Medicine. Again, I was sitting on the committee at the time that this came out, and this was really a game changer in thinking about, how do we treat mastitis? What is it? What does it look like? What are we supposed to do? And in the past, it was really kind of this idea that, oh, we need to soften things, we need to heat, we need to use compresses, we need to use a lot of massage to try to work things out. I remember, telling patients that they needed to use electric toothbrush or any other vibrating objects that they had, to really try to work out these plugs and to get things going. And this idea that the worst thing that you could do was to rest the breast, that you had to really keep going, didn't want the milk to build up, that was going to make it worse. And unfortunately, we found that was actually doing more damage than good. And I want to give a shout out to Dr. Katrina Mitchell, that some of these slides are borrowed with her permission, from a presentation that she gave at the Academy of Breastfeeding Medicine annual meeting back in a couple years ago now. And really recognizing, why did this not work? Well, a lot of it comes back to why a lot of our issues around lactation and breastfeeding don't work, is that we really don't know how it works. We don't know what determines how much milk an individual makes. We don't know what determines how the content of the milk changes throughout the day, what determines how much volume is going to be there. And because we don't have that fundamental understanding of how the organ itself works, of course, we're going to come up with things that are not necessarily the optimal ones to be able to move towards health. And that we have a tendency, this is often a phone in thing. So someone calls in, they're having an issue. We say, oh, just start antibiotics. It'll make it better. And we don't go back and actually address what are the underlying reasons that are causing this to happen? What are the other factors that we need to be addressing? And because we have now become so reliant, for many individuals, on pumping and getting away from physiologic feeding, anyone who has nursed an infant knows that when they don't want to nurse, they're not going to nurse. You can put them at the breast and they will have absolutely nothing to do with it. And yet the pump is not going to stop. The pump is going to continue to express milk while it is turned on. Just like an infant, if you put a bottle in their mouth, they're going to continue to take it. And so we've moved away from some of those physiologic clues. And so this really takes kind of a reframing of our understanding about how this spectrum of disease, it's not a single pathologic entity, but it really is this kind of structure. And this was a schematic that is in the protocol. It was from Pamela Barron's originally, and it really kind of talks about this sequence of events that happens and can be in various orders depending on what all is happening. But really, it tends to start with this combination of either hyperlactation plus or minus dysbiosis. And dysbiosis is really just kind of a fancy name of talking about some kind of disorder within the microbiome of the milk. And we're going to talk a little bit more about that. But really then goes into this cascade. So starting from that, you start to get ductal narrowing. start to get inflammation and edema that's there, then potentially progressing to bacterial mastitis. And if that is left untreated, it may even progress to an abscess. And there's a couple various pathways that can go where either that blockage can then cause a buildup of a milk, that cyst that can develop, and that's a galactocele. And potentially by going in and draining that, we can then lead to an infected galactocele. Or if there's repeated trauma from that area of inflammation and edema, can then develop a phlegmon or a firm mass that can happen. And really how all of these can go together to cause challenges. So this is really a schematic talking about what's supposed to happen. What is it supposed to look like? First off, our breast tissue, very similar to the vagina. It's not a sterile place and it's not supposed to be. That's not how it was designed and that's not how it's supposed to work. And so there should be these healthy bacteria and it's going to be a heterogeneous population. So we're going to see all these different colors, all these different types of bacteria that is there that makes up the microbiome of that healthy lactiferous duct. We're going to see that mammillary epithelium on either side, and we're going to have that normal milk flow that's going to be able to go through. So if we were going to culture this, yes, we're going to see that combination. This is open to the air through those sinuses within the areola, that milk that is going to be coming through. This is how it's supposed to be working. And the problem, once we are developing hyperlactation, or having that dysbiosis is happening, is that rather than having that mixture of bacteria, we start to get an overgrowth and it becomes a homogeneous population. And that's when we start to get concerned about the development of those biofilms that, in addition to the edema and the inflammation, which are causing narrowing, that is going to limit the amount of milk that's able to come through those ducts and eventually may cause so much pressure and edema that we're not able to have that milk passing through in the way that we would expect it to happen. And so they've actually been able to do some electron microscope work to actually look and see what this looked like. So on the top left, we can see that healthy mammary cells, that combination of that heterogeneous mix, and instead developing this homogeneous single type of bacteria where we get that biofilm that is developing. And we still don't fully understand why this happens. There are probably genetic components. So there are probably some individuals who have a higher susceptibility to this. It may be related to some of the things that happen during pregnancy. That may be related to mode of delivery. So C-section is one that has been proposed to maybe potentially have an influence. It may be related to antibiotic courses. It may be related to probiotics. There's a lot that we still don't fully understand about what is happening with this combination. But really, regardless of how this happens, what then happens is that we get stuck in this freeway model. And so essentially what we, are thinking about is that there's this narrowing. We've still got all of these cars trying to get through, and that's going to cause more and more backup and more stress on the system. When we think about the breast, it's not a static repository. It's not like a bladder that's going to fill up with urine and empty. That's not what's happening with the breast. We do get alveolar distension when the alveoli are full of milk. But there's constant feedback inhibition, and that feedback inhibition of lactation, the FIL, is constantly helping to regulate based on how much milk is being removed. And so the challenge with that recommendation that we've had in the past of, oh, just keep nursing, just keep pumping, focus on that side, really work it all out, is essentially we were just adding more cars to the traffic jam, which was making it more and more difficult to actually recover so that folks were not stuck in this ongoing system of the traffic jam and what couldn't get through. Now, it is important to clarify and to make sure that, that our breastfeeding moms really understand it's not like there's one pathway. There's not only one exit, so it's not like a single duct is going to get plugged with this. There are so many different pathways and entrances and exits to this freeway that all of those other pathways are still there. But if we're getting increasing inflammation and increasing edema, that's then going to back up and impact the rest of these systems as well. But there's lots of different openings that are going there, but really trying to get away from this idea that there's one set spot that's plugged, and if you can just get rid of that, that's going to take care of it. Really trying to move away from that model and to really shift our mindset, that some of the things that we do for other organ systems that are inflamed and have edema is that we rest them. So whether that's a bowel obstruction, if somebody's bowel is blocked, we're not going to say, oh, just keep eating until it unblocks and that's going to make it better. So whether that's a gallbladder that's inflamed, or someone has pancreatitis, or my favorite is a sprained ankle. So if somebody goes out and they sprain their ankle, our first recommendation is not, what you really need to do? You need to go run a mile. Just go run a mile. It's going to make the ankle better. Just keep going. We've been using completely opposite with what we've been telling our patients with breasts, compared to what we do for any other organ system when they're inflamed and have an injury or have that irritation. And so really shifting that framework to think about, what would you do if you sprained your ankle? If you sprained your ankle, you tweaked your knee, you're going to rest it. You're going to take it easy. And so that's kind of the biggest difference and the biggest change within these guidelines is those initial conservative measures. What are we doing when folks first start to notice these changes? And the goal is really to get down that inflammation and edema, to unblock the freeway and to make that easier. And so we're doing all the same things that we would do for that swollen ankle. We're going to get ice. We're going to use high dose ibuprofen and acetaminophen. These are the doses that we use right after surgery for folks. We're using the same thing because we really want that tissue to have that time to heal, to continue to nurse or express milk for comfort. But the goal is not to empty the breast. The goal is not to get to that empty state, because what we're also wanting is that if hyperlactation is part of this, is that milk sitting in the ducts is going to help with that feedback inhibition of lactation to self-regulate the supply and to help decrease oversupply if that's contributing to this. The others is to try to make those cars on the freeway smaller. And that's really what we think about, sunflower or soy lecithin is just to make that milk less chunky. And that's another option that we can use as well to help decrease. This is from the Physician Guide to Breastfeeding.org. That's again, Dr. Katrina Mitchell's organization. I'm thinking about BAIT for 24 to 48 hours. So breast rest, Advil, ice, Tylenol, if that helps folks to think about this a little bit easier. And again, what we're really trying to do is decrease that inflammation, decrease that edema, and allow those ducts to reopen so that milk can freely flow, so that they're no longer compressed and collapsed because of all of the edema that's around there. Again, that's why massage can potentially make it worse of those areas, because we're causing more tissue damage, more destruction. And here's really that if we've got a bridge, if we're stuck on the I-5 bridge, anyone who's tried to get through Portland knows it's slow traffic until you get to the bridge. And as soon as you get over, it opens up, even though there's nothing different. The number of cars is the same, the number of lanes is the same. We're really trying to think about how do we get that inflammation and edema down. And so, either making that milk less chunky, decreasing that edema. I do want to clarify, lymphatic drainage was also included in the protocol, which is something that folks may not be quite as familiar with, and really making sure that it's clear that this is different from massage. It's actually going in the opposite direction. So it's going away from the areola. It's helping to decrease some of that edema, move that fluid back into the lymphatic space instead of within the breast. And it's very gentle, or like petting a cat. So I like that analogy to think about this, and really just helping to move some of that pressure away. This can also be used during pregnancy. So if folks early in that first trimester are noticing kind of some of those early changes in breast development and it's uncomfortable, this can be one that can sometimes help with to increase some comfort, or if they're developing engorgement right after delivery, that this can also be used. This is not, these conservative measures in general, we're recommending for about that first 24 to 48 hours. We recognize that some folks are certainly going to go on to developing worsening symptoms and develop the systemic symptoms that we so often think about with inflammatory systems, is that fever, tachycardia, feeling poorly. We hear it described as being hit by a truck. Any of those times, first we want to make sure that we've done all the conservative measures. If we've done those and it's still getting worse in that next 24 to 48 hours, then that's when we really want to go ahead and get those antibiotics started. So it's not, there was some confusion, I think, when this protocol initially came out to say, oh, they're saying never use antibiotics. No, it's really, if those conservative measures are not working, if we're not fixing the underlying system, issues, then we do need to go ahead and use the antibiotics. And those are probably going to need to be, 4 times a day for 10 to 14 days. We really want to make sure that if we are using antibiotics, we're treating it completely, so that we're not stuck in the system of, is it recurrent mastitis? Is it happening again? Is it the same thing? Is it something different? That we're really able to move forward. And so, again, this is included in the protocol. It's there, all of that information. And then as we're going throughout this, really paying attention to how is mom's mental health. This can be incredibly stressful to be going on. These complications are traumatic and painful. And one of the things that we're really trying to get away from is oftentimes people are given conflicting advice, whether that's from friends, whether that's from well-intentioned family members, whether that's from healthcare providers and community resources, and all of these, really trying to get us all on the same page so that we're giving that consistent advice. And that so many patients just want to feel heard, to make sure that their concerns are validated, that what they're experiencing is being acknowledged. And, when we struggle with this, when we don't do it well, then we know that that leads to so many of those worsening mood symptoms going forward. This was one of my colleagues had put together some of the key points that we actually share with patients. And, we try to provide a lot of anticipatory guidance. So talking to folks about, what happens if you start to notice? If you start to notice that, gosh, it feels a little uncomfortable, you were carrying the diaper bag on that side, and now it just feels a little, here's some of the early things to be able to do to hopefully work this out so that we don't, and work this out is not a great, because again, we're resting it, we're not trying to massage something out, to make sure that we're able to move forward, and that we're really working closely with all the members of the healthcare team. One of the challenges and the struggles that I often think about with breastfeeding and lactation is that there's no one specialty or group who owns it. And that also means that unfortunately, often there's not one group who takes responsibility for the complications. And so is that obstetrics? Is that pediatrics? Is that family medicine? Is it our IBCLC colleagues? Is it our doulas? Is it our midwives? Where do we all work together? And how do we make sure that we're working together to really optimize health and to make sure that we are working together for our patients? So those are some of the big things that I wanted to make sure that we got to cover about some of the mastitis spectrum. So let me take a pause there, a breather there. What questions can I try to help address, or what ongoing things before we move on to some of the lactation at any size parts of things?
There's nothing yet in the chat, but feel free to come off mute and ask any questions, or type your question in the chat and I can read it aloud.
And if folks want to have time to think about things, we can always, there will definitely be time at the end as well. So don't feel like you have to get it out right now. Okay. Well, let's keep going. And again, feel free to stop me at any point. So, for this part, we're going to talk about some of the modifications we can make in our clinical setting to reduce weight stigma, understand some of the limitations of BMI and the impact on breastfeeding dyads, and really kind of leaving with more questions and answers and a curiosity to challenge some of the assumptions I think about for a lot of the mastitis things, this was really kind of moving away from what had been done for a long time to think about what are some other ways that we can do things, what are some differences, and my hope is that that will also help to drive things forward. So, when we think about elevated BMI or obesity during pregnancy, we know there is an increased risk for metabolic dysfunction, and that birthing persons with obesity are significantly less likely to exclusively breastfeed. So, less likely to initiate breastfeeding, more likely to start earlier supplementation. And the distinction between the underlying physiologic factors impeding successful lactation versus breastfeeding support is critical for determining the interventions. A lot of the studies that have tried to, we take those, okay, less likely, then we just need to throw more support. We need more support groups. We need more pillows. We need more. Anyone who is feeding another human needs all of those things. There is no question, 100%. They need all of the support in the world, especially since we are in a culture and a society that does not prioritize breastfeeding. That being said, if there are underlying physiologic factors that are impeding the ability for an individual to meet their breastfeeding goals, all of the support groups in the world are not going to change those underlying physiologic challenges. And that's really where a lot of my interest in this topic lies. So this is now over a decade old. This was from a conference back in 2012 that was about lactation, defining and refining the critical questions. And I like this schematic because it kind of talks about the complex interplay that is happening during that first 1,000 days. So for those who may not be as familiar with the developmental origins of health and disease, it really focuses on this first 1,000 days period, which is the 3 months prior to conception, the 9 months of pregnancy, and then the first 2 years of life, and looking at the huge part that mammary glands play and the complex interplay between what's happening from a hormonal level, what's happening with the infant, how those psychological interactions are influencing all of this, and that this is really the critical time period for laying that foundation for health throughout the lifetime and the lifespan. And that's why it is so important for the incredible work that you are doing to make a difference during this critical time period. That's why we're talking about all of these things and to try to figure out what are the things that we can do. So, we're all really familiar with this table. This is the gestational weight gain, published back in 2009 by the Institute of Medicine, now the National Academy of Medicine. They gave these great, easy to understand, check the BMI, get this. Unfortunately, there's some major limitations to this. So number one, as a provider, I've been given absolutely no tools for how to help a patient actually gain 25 to 30 pounds instead of 11 to 20 pounds. Like, I have no idea how I am supposed to help the patient, the person sitting in front of me, to actually be able to meet these guidelines. And the other huge limitation is that this is based off of pre-pregnancy BMI. So how good is BMI at actually determining an individual's amount of fat mass? And this was a question when I came to the end of my fellowship that I was like, but wait a minute, how do we even know what these categories are or what they mean? And so this was a study that I did with funding through the Oregon Clinical and Translational Research Institute. And it was a pretty small study. It was a pilot study. We had about 41 pregnant people, and we did measurements with a bunch of different methods to try to figure out how much fat mass did they have. And what we found on the top left, that was the fat mass in kilograms by each of the categories. The top right is looking at the percent body fat. But what I thought was really kind of fascinating is when we take an individual whose BMI falls into the overweight category, there is a huge amount of overlap with the other two groups. And I can't look at an individual and be able to tell they may have fat mass that is the same or lower than an individual with normal BMI. They may have a fat mass that is higher than an individual with obesity. And unfortunately, especially in pregnancy, it's just not a great tool. And yet we're supposed to change our clinical care based off of that. The other thing that was fascinating as I was looking at this was, well, what about gestational weight gain, and how does that matter? What happens? And we have kind of this assumption that gestational weight gain equals weight from fat. So individuals gaining more weight, they must be gaining more fat, right? I mean, that has to be how it's happening. But is that really true? And have we actually looked at that? And so my apologies. I know this is a really busy figure. To break it down, on the x-axis, we have individuals with normal weight, overweight, and obesity. And then by each of the categories based on the Institute of Medicine guidelines. So inadequate, recommended, or excessive gestational weight gain. On the y-axis, we have kilograms. So the blue follows exactly what we would expect. Again, this is looking at the blue is gestational weight gain. For each of those, it goes up the more weight you gain. Follows perfectly what we would expect. The red represents the change in fat mass across the course of pregnancy. So for individuals with normal weight, it follows exactly what we would expect. So as individuals gained more weight, they gained more fat mass. And that all of them, even those with inadequate weight gain, gained fat mass during pregnancy. Great, makes perfect sense. The real interest comes when we look at individuals with overweight and obesity. Because in those groups, for individuals, all of them gained weight, except for a few of those folks with the obesity group who had inadequate. The others all gained weight. But for those with inadequate or recommended gestational weight gain, they either maintained or actually lost fat mass across the course of gestation. And it was actually only the individuals who had excessive gestational weight gain who actually added fat mass. And even then, they gained less fat mass than those individuals of normal weight who had excessive gestational weight gain. And again, one of the major challenges when we think about gestational weight gain is that we still don't understand what is really happening with those changes in weight across pregnancy and what those fat stores are doing. And one of our questions is, does an individual need to have additional fat mass laid down in order to be used as stores for breast milk production? Or can an individual access their existing or underlying fat stores to be used for lactation? We don't know. No one has really looked at that question or tried to answer that and to figure out, is all of our emphasis and our focus on limiting gestational weight gain and attention to this, is all of that potentially impeding some of the normal physiologic changes that we would expect to happen to facilitate the ability to exclusively breastfeed? We don't know. Again, more questions than answers, and unfortunately plays into this. This was from Huffington Post back in 2018, that everything you know about obesity is wrong. I would say, they could have easily said everything we don't know about lactation is probably wrong and right, because we don't know. We just don't have the questions, but we know that we have the potential to do harm based on the limited things that we do know, and especially the things that we're really confident about, recognizing that a lot of those we don't really have the data. So when I'm thinking about weight in pregnancy, I love when my patients bring up weight because it gives me an opportunity to talk about nutrition, because I do care about nutrition. I care a lot about nutrition. And so when my patients come in and say, gosh, how do you think that, tell me about your nutrition. Tell me about, what are the things you enjoy eating? Are there things that you avoid eating? Are you getting seafood? Are you eating eggs? Let's talk about your activity. What are the things that you enjoy doing? All of those things make a difference. And those are the things that I think actually do matter and do have a lot of importance, much more than the number on the scale. Now, there are situations where I really do need my patients to be weighed, or it helps me. For example, if I have a patient who has been diagnosed with gestational diabetes and their fasting blood sugars are going up, and we're having the conversation about starting insulin, I may ask their permission if they are willing to be weighed, because I'm going to use that number to help me guide the amount of insulin that I'm going to start them on. But I'm going to explain to them why I'm using it, why it's important, and how it's going to impact their care before making a blanket assumption about whether that number on the scale is going to tell me something about their health or the health of their infant. So when we think about how this then intersects with breastfeeding, this comes back to what we just talked about. So, women with obesity are less likely to intend to breastfeed decreased initiation, shorter duration, less adequate milk supply, and more likely to have delayed onset of lactogenesis stage 2, or to have the transition to mature milk after delivery. And in this, over a decade old study now, they looked at the possible explanations. Why is this happening? Why could this be? And it comes back to that, well, gosh, maybe it's a size issue. Maybe they just, you can't latch with the areola and the breast size. Well, they just say that it's harder. Oh, it's a social art. It's learned. It's maybe it's body discomfort and body dysmorphism that more uncomfortable. Oh, it's related to lower socioeconomic status. What we don't see in there are really those physiological factors that we've talked about. What about on a metabolic level? What is happening? Is that influencing the ability to have lactogenesis on time and to make a full milk supply to be able to support exclusive breastfeeding? This was a more recent study that really called out that yes, there are multiple challenges, and they're both unique challenges and similar challenges that are exacerbated by their obesity. So going to still have positioning difficulties. They still might not have, that perfect hold, but it's going to be to a greater degree or a longer duration. Less confidence going into it, especially those who don't have breastfeeding experience. They may be experiencing more health concerns after delivery. Do they end up having a C-section? Do they end up having an infant that had hypoglycemia that now had to have supplementation? Are they having the support that they need? And all of these, again, are going to drive what we are going to be able to do. So I really wanted to try to get a better sense of what's going on. So as part of my subsequent study this was funded through the National Institute of Health, National Institute of Child Health and Human Development. This was a study of 104 individuals who intended exclusive breastfeeding. So 100% of the participants in my study intended to breastfeed. As I was looking on the Oregon WIC page, it looked like there was about a 94% breastfeeding initiation. That's amazing. That's incredible, and is something to be incredibly proud about. Almost 92% of the folks in my study intended to exclusively breastfeed. No one intended exclusive formula, and they all started breastfeeding. So again, we are definitely in a culture where breastfeeding is encouraged and supported for so many individuals. And so this is exactly what we want. This is starting where we want to be. And so when I looked specifically at the 92% of folks who intended to exclusively breastfeed, and this is what I consider my death of exclusive breastfeeding chart. And that, again, of these individuals, all of whom intended to exclusively breastfeed, by 6 weeks postpartum, I saw a dramatic difference based on pre-pregnancy BMI. That while almost 91% of the individuals who started pregnancy in the normal or underweight were exclusively breastfeeding, this dropped to 68 and 65% in individuals of elevated BMI, and this persisted. So by 6 months postpartum, 79% of individuals of normal BMI had met their exclusive breastfeeding goals, compared to 34 and 42% of the individuals with overweight and obesity. And again, these were all individuals, their goal was to exclusively breastfeed. This was their intent. And yet, for some reason, they were not able to meet those goals. And again, those numbers are incredible. When we look across the country where, nationwide, it's like 23%, we're well above those numbers. But again, these are individuals who are not able to meet their goals. So I was like, great, my next study, I'm going to submit, an R01, the big grant to study what the factors are of this. And as I put that in, the summary statement that I got back included in the weaknesses, this analysis lacks consideration of established risk factors for breastfeeding failure, such as education, socioeconomic status, family support, lifestyle habits, depression and anxiety, etc. All of these things that very much wanted to move away from any potential physiologic factors that might be influencing these ability to meet their breastfeeding goals. So we're much more comfortable saying, oh, it's those lifestyle habits, it's nutrition. They just didn't want it hard enough. They didn't try hard enough. Did they really want, if we just told them that it was important and we told them that it was good, then they would have tried harder, then they would have done more. Like, no. Certainly, again, all individuals who are breastfeeding need to have more support and need to have more encouragement. um, but at the same time, just because we have individuals who have a stroke or have a heart attack, we want them to do all these things. We also look at what are the things that we as a medical system, what are the treatments, what are the medications, what are the things that we can do? And unfortunately, at this point in time, we don't have those things to offer for our individuals who are not able to meet their breastfeeding goals and are not able to produce an adequate milk supply. So in response to their concerns, one of the follow-up manuscripts that I published was really to try to look at so many of those factors. So, we looked at the breastfeeding, the baby-friendly hospital initiative, those initial factors such as, immediate skin to skin, first nursing session within the first hour of life, feeding on demand, all of those things, and found that there was no difference between individuals of elevated BMI and those with normal BMI. If anything, the folks with elevated BMI had more time off work and were more likely to have stronger family support and encouragement, and yet they still were not able to meet some of their underlying goals. So I do think that there is so much more work that we need to do to try to answer these questions and to be able to help our families to do what they want to do. So kind of pulling this together and hopefully starting our discussion, BMI has its limitations, know why we're using weight. We understand that folks with elevated BMI are less likely to meet their goals. What we don't understand is why, and then how we can best support their journey. And then the language that we use matter. And we also need to be aware of our own biases. And I'm calling myself out or calling myself in as much as anyone else. This is a manuscript that I published over a decade ago. Super obesity, maternal, super obese, nulliparous women, the language that I used in that. And really, I am very intentional now about using person first. That everything that we should be doing should be talking a person first. And so when I'm reviewing a manuscript, when I'm reviewing a grant, I'm going to call the authors out on that every time if they are not focusing on the individual in front of them, or that they're writing about, rather than using that, focusing on weight first and leading, and being aware of our own biases, because it has the potential to negatively impact our patient care. And I had an experience not long ago that really kind of brought that to my attention, my need to constantly be aware of this, that I had a patient who was coming back in for, one of her postpartum visits. And this was an individual who had had a very early delivery, had a classical C-section, so has an infant in the NICU, very low birth weight, elevated BMI, woman of color, all of these risk factors. And so I asked her, how is breastfeeding going? Tell me about your pumping schedule. Tell me about what's happening. And I want to get into the details. I want to do, okay, so tell me, how much are you pumping? And she said, oh, well, about 6 ounces. And I was like, okay, so is that throughout the day? Is that, she's like, no. And she kind of looked a little sheepish. And she said, well, that's each breast. And I was like, wait, what? 6 ounces each breast? How often are you pumping? And she's like, well, every, at least 8 times, but I try to get 10 in if I can. And so realizing she was pumping 12 to 14 ounces every 2 to 3 hours when she has an infant who is still under 30 weeks. So she has a massive oversupply, massive hyperlactation, huge risks for all of the things that we talked about. And I said, oh my gosh, we need to, are they aware? And she said, well, the NICU has asked me to stop bringing in my milk. I said, well, we need to work with the nurses and our lactation consultants, and we need to, and she's like, well, I told them, but they didn't believe me. And it went back to those biases that they saw this individual, woman of color, elevated BMI, emergency cesarean, all of these things, and didn't see that she was actually experiencing hyperlactation oversupply, that was the medical issue, and that was what we needed to treat to prevent her from going down that pathway. And fortunately, we were able to get her in with the folks that we needed. But really recognizing that each individual in front of us is going to have their own story, they're going to have their own experience, and what are the things that we can do as the care team that are surrounding them to help answer some of those. So it is never too early to be encouraging breastfeeding and to making sure that we're making that the norm within our communities. And so I thank you for this opportunity to chat about a variety of things, and I welcome your questions and discussion. So let me see if I can figure out how to stop sharing. I think now I can see the chat. So if there are folks that have anything in there, let me know.
This is Kristen Chatfield. I'm a researcher at the state. And so I feel like this is for the local agencies, but I just have to speak up and say, I am utterly besotted with your approach, and I really appreciate everything you have shared. And that certainly rings true. That individual approach, as I was very lucky to be in a fecund group of friends and family all at the same time, so we could share our experiences, and oh my, how they were very different. And yeah, we try to sort that out in our data as we work on our Oregon WIC breastfeeding data. And I will share, and I just haven't been quite sure how to talk about this, but we don't see some of those huge gaps by race in Oregon the same way. We still see, yeah. So it's like, there are still some gaps, but not those big glaring ones that we see nationally. So we'll keep kind of thinking about how we want to talk about that, because we also don't want to suggest that there's no problem, everything's hunky-dory here, because that would not be accurate either. But just really shout out to all these folks that are on the call who support our participants so well, so that WIC families initiate and manage to breastfeed the same way that other families do in this state. So thank you again so much for being here.
Thank you for letting me know. That is huge. I'm so impressed with the work that is being done. What else?
There's lots of love in the chat, Dr. Marshall. Tiffany says, as a plus-size woman who was pregnant with her first baby, this spoke straight to the areas of my heart that needed it. As a doula and IBCLC, I know a lot of this information, but it is so meaningful and impactful to hear it from a provider in my community. Thank you for the important work you are doing.
Thank you. Yeah, and I think it's one of the challenges that we know everyone's going to have their own experience, and it remains frustrating to me that the folks who often end up getting interested in this area are the folks who have unfortunately experienced trauma in order to get into this field. And so I'm still trying to figure out a way to encourage, my trainees. I have the privilege of working with medical students and residents and fellows, and our nurse midwifery students, and so many folks. And really trying to figure out how do we harness that excitement and that willingness to take their interest to really get more folks to be trying to answer these questions, and to get funding organizations to recognize the importance of this. Not only, we are impacting the health of multiple generations and future generations. And so, I have so much respect for all of the work that that you are doing and that is happening across our state with, so many of our families. And I really look forward to ways that we can continue to partner together in the future.
One thing I was really struck by is this notion that of not getting support for doing research on the physiological problems underlying. Here's our medical system that tends to focus on, what's the biologic or underlying factors for challenges, and yet they're not willing to believe that there is, in fact, those physiological problems with breastfeeding. And yet it feels like a lot of the data that you're sharing really points to the fact that there is, but we just don't know.
Mm-hmm. Well, I think, when I tell someone that I have no idea, I have no ability to determine how much milk, what is the capacity of an individual breast, and that it is different for many individuals, that each breast has a different, and people go, well, what do you mean? What is that? I mean, just understanding of the basic biology of the organ itself. And so how in the world are we going to have the tools to be able to help to alter or change the trajectory if we don't even understand how it is supposed to work, how it normally functions and works? And I think, unfortunately, it goes to a lot of the biases that we see when it comes to women's health and women's healthcare. Whether it comes to obstetric management, whether it comes to, the latest one that we've seen is, that providers should be paying attention to pain with IUD insertion. Of course we should be paying attention to pain. Of course, that shouldn't, why did it have to take multiple studies for us to recognize that this is a really important thing that we need to do, just like we would for any other condition and any other, and yet somehow we've been able to say that the breastfeeding is different, or, it's natural, and therefore, we shouldn't have to do all of these things. I think it's a really frustrating to have to keep knocking on those doors. And when I give similar versions of this talk to colleagues at NIH and program officers, inevitably one of them will come up to me afterwards and say, "I didn't know any of this." I want to say, I know. That's why I'm really struggling to get this funded. So let's see. Okay. So looks like in the chat, trying to help them find the balance of feeding or pumping to comfort, but feeding the infant to their needs is sometimes difficult. If that makes sense, it makes sense in my head. I think it's a great question, and that balance of what is comfort, what does that mean, what is supposed to be uncomfortable, and that we really still don't understand exactly how FIL works, the feedback inhibition of lactation, how that hormone works. And so to be able to directly target it, to be able to do what we need to do. So in general, for my patients, when we're stuck in that situation, is that I will often say, okay, nurse to comfort on that breast first. And then once it feels comfortable, switch to the other, or vice versa. Have the infant feed their full. If they're still, not completely full, then switch to that breast. And if you need to still do a little hand expression or a little bit of pumping, it's much harder for my patients who are exclusively pumping, because they really don't have that ability. It really then does just become to comfort. And I will often say, try to match what your infant is feeding. So if you know that your infant takes in this much, your goal is to pump exactly that much. And I think especially those of us who have struggled with low supply, we develop that fear that there's never going to be enough, and it's always more important to pump as much as we possibly can. But really recognizing that if we were just with our baby 24 hours a day and we were always directly feeding, there wouldn't be any extra milk, because why would we need to make any? And so, really trying to have them target their expression to match exactly what their infant is feeding, rather than going above that, if that kind of helps. Okay. How can we facilitate and or help our nursing community that aren't as well treated in their journeys? I feel like this is a large hurdle when we as IBCLCs follow what you were talking about, but providers are still stuck in the dogma of old research. Yes, you have unfortunately hit one of the really uncomfortable things about this. And I think it often puts folks in a really uncomfortable position. And I think more power to you. My hope is that providers are open and we are spreading this message. We are giving grand rounds. We are talking about it in group forums. The biggest thing that I tell, especially my trainees, is if you don't know, ask. Ask someone who actually does know. Don't try to make it up. Don't try to, because then you're potentially doing harm, even though you're not meaning to. So if there is ever a time that I can be a resource or I can be of assistance or, pulling out, oh gosh, I see on this protocol, we've tried this and this isn't working. It's really hard because I think lactation is again one who are biased by their experience and their training, if they even got any breastfeeding education. And I think for a lot of folks, they're not keeping up with the latest guidelines. So even though these are now 2 years old, there are a lot of folks that have never heard about this. And have never kind of gone back to being aware of some of these guidelines. So yeah, to be a supportive team and not counter advice, that is so hard. We experience that here, despite the fact that, we try to talk to a lot of different people. And I'm often just really upfront with my patients that, how we talked about that I can't tell you when you're going to have your baby. Like I have no idea unless I am doing a C-section and I am starting it at this time. I have no idea when your baby is going to be born. Unfortunately, there's still a lot that we don't understand and we don't know about lactation. We don't know about breastfeeding. And because of that, you may get a lot of different advice. And I'm going to tell you what my experience and what my training and where I get this, but recognize, unfortunately, there probably is going to be that. And trying to help patients feel like we're not intentionally trying to lead them astray and drive them crazy. And unfortunately, I think it's one of those that we're just going to have to keep fighting and keep sharing that message. And hopefully it gets back to providers and that there is a willingness to learn and a willingness to ask for help when they're not sure about things. Thoughts on using the birth weight as the baseline for weight loss? So using the amount that the baby weighs, can you tell me more about that one?
Can you hear me?
Yes.
So when they take the baby in for their 2-day check or their 2-week or 1 month, and they're focusing, well, it's mostly the 2-day and 2-week, they're focusing on that 10% weight loss, but it's based off their birth weight when we know they're swollen, full of fluids, whatever. And I feel like it causes a lot of parents to supplement quicker than they normally would. So I was just curious of your thoughts. I know it's not part of this presentation, but
Yeah, it all goes together. And actually, I'm working with one of our medical students right now, and I debated about throwing this slide in there, and I didn't actually because she hasn't presented it yet. But one of the things that we actually did is we went back and looked at, again, so much of my focus is on, are we helping our patient actually meet her goals or their goals? And so we actually looked at the 6-week mark for folks who said they had met their goals versus folks who said that they hadn't met their goals. And we looked to see, were babies more or less likely to be back to birth weight by that 2-week mark. And that we found that of the women who said that they had not met their goals or were less likely to have met their goals, they were also much less likely to have infants who had regained who were back to birth weight by that point. Probably reflecting some of the concerns about supply. And again, it's hard because it gets into, okay, low supply. Is it really low supply? Is it not low supply? where is this? And I think that's one where all of, the work that you are doing in those early days, I mean, that is the critical time period. Because, when I'm talking to our students and our trainees, there's three key things: feed the baby, protect the milk supply, support the family. Those are always the key things. Number one, feed the baby. We don't want this to be in a situation where we've got failure to thrive and infants who are not meeting that. But as you say, there is a lot of pressure on patients, especially oftentimes from family support. The goal is that chunky baby. That is, everybody wants those cute little cheeks and those cute little rolls and all of those things. And gosh, the baby seemed satisfied when they finished at the breast. But, I put that bottle in their mouth and they just took it like there was nothing. And so, I do spend a lot of time talking with my patients about what are normal physiologic clues. What does it look like when your baby is hungry? If your baby's moving their tongue all around, what does that mean? How do you respond to that? What does it look? What does a satisfied baby look like? How do you know if they're satisfied? How do you know if they're getting enough? Unfortunately, we don't necessarily have a culture where that is the norm and where people have seen breastfed babies and they've seen, that. And so, oftentimes, and for many of my patients, especially if they have babies who are in the NICU early and they start pumping, they just continue pumping rather than ever switching back to the breast. And part of that is they can control the intake, they can control the amount, all of that ties into so much of those pieces of education that we can, to say, a baby is always going to be willing to take a bottle. You put the bottle in their mouth, most likely they're going to suck on it and they're going to take it. But if you put a baby to breast and they don't want to nurse, they're not going to nurse. Those are different physiologic cues. And unfortunately, it's not until we're probably 2, 3, 4 years old, you put a bowl of ice cream in front of a 1.5-year-old, when they're done, they're done. They're not going to keep going. They haven't learned to override those signals yet the way that we have. And so, really trying to work on those cues, that our goal is not to top off babies. And especially for our growth restricted infants, I spend a lot of time talking to those parents about, your child is going to be on a different growth curve. I want them on their curve. I want them growing, but my goal is not for them to have rapid catch-up growth. I don't want them to go from the 5th percentile to the 95th percentile, because we know that those infants have likely undergone epigenetic modifications in utero that they are going to increase their risk for later development of type 2 diabetes, of cardiovascular disease, of all of those things. And so our goal is to keep them on their curve, not to keep up with their neighbors. And that can be really hard when they're getting family pressure to have the chunky baby and the big baby. So I know, we've been using with our pediatric colleagues, using those kind of new guidelines and trying to help to look at those early days. But I think so much of that is just, what is normal? What do we expect? Where should babies be? When do you need to be worried? When do you need to be concerned? And when is this normal for an infant at that stage? But it's a great question. Yeah, and using local lactation coalitions, using different groups, all of that is trying to work with our community partners to make sure that we're on the same page. Having folks come into visits with us, that also tends to be really helpful. Yeah. Other questions or comments or discussion? What are the things that we can be doing in the hospital to better support you? Oof.
Sometimes I wonder how we can take our culture in Oregon and, I feel pretty good about it and bring that over. I know I mentioned family. I have a sister and sister-in-law that live in the South, and I did not see them breastfeed. They did, but it was always like, you go away, very separate. All raised in the same families, whereas those of us who are on the West Coast were like, baby's hungry.
Mm-hmm. Yeah, it would be fascinating. I do wonder, what is it about the culture here? I mean, to the point that I don't know if anyone has seen the Simpsons episode that is based in, I can't remember if it's based in Oregon or based in Portland, but essentially, she pulls out a bottle to feed Maggie, and the other mothers all volunteer to feed her at the breast instead. That is so much of the culture. But I wonder about, where is that coming from? How do we get that? Is it that the intent is so much higher and therefore the initiation is higher? What are the barriers to initiating breastfeeding in so many other places? And I think it's such an important question about how do we make this the norm? And yet at the same time, I don't know if guilt is the right word, but when we exist in a culture that doesn't prioritize, that doesn't value, it's the same kind of struggles that I have with ideas that, we're going to demonize pregnant people for what they eat or what they do during pregnancy. And yet we as a society do not value nutrition. We don't value getting, whole foods as opposed to ultra processed foods. That's not what we have created as the expectation. And for us to expect pregnant people and lactating people to behave in a different manner, goes into so much of the misogyny that unfortunately affects how our laws are and how we don't support. So, what is it that we are doing well? I don't know. I wish I knew, but I know that we have the opportunity to do research and to do work in this area that is different than in a lot of places. And that's part of what makes me really excited to be able to ask these questions here. Um, okay, another question. Communication from providers on the goals for the early babies, 100%, being on the same page with parents and families and with pediatricians, and family providers. Can you speak to the lactation training that OHSU providers receive now? My understanding is that there are no baby-friendly hospitals in the area anymore. So yes, I was part of the group that did all of the training of, we designed the curriculum for our providers. We trained all 280 maternal and pediatric providers at OHSU. And then for budgetary reasons, OHSU decided to not continue with the process. And that was around the same time that I believe Providence had decided to let their certification lapse as well. And so it is a great question. Honestly, what we are doing, at least for our division or for our department, is that there are now 3 IBCLC OBGYN providers in our department. And so we do an orientation each year for all of our incoming interns. And then also that I do one for our MFM fellows, to really try to make sure that it is very apparent that this is a part of their training. This is a key part of what they need to do. I used to love that it was a multidisciplinary with our certified nurse midwifery students, our family medicine residents, our pediatric residents, and our obstetric residents. And it became a struggle to try to get all of that scheduled within the first week. But that is an excellent reminder that I need to go back to the department chairs and the division heads from those divisions to talk about why this is so important for us to be doing. And for our new faculty, it's a great question. We're trying to make sure that we have at least 1 or 2 lactation specific grand rounds that happen each year. And it's not enough. There needs to be much more ongoing training, but it's a good reminder of what we all need to be working on. Other things?
So this is Mandy from Baker County, and just speaking of the ways providers can be helpful, and I know we're kind of out in that rural area, is one of the problems I run into is our providers aren't using a measuring board. They just use the exam tables, and oftentimes they're telling moms babies are underweight because they're saying their babies are above the 99th or, the 99th percentile, but really above that 99th percentile in length. So they're underweight, and they really aren't underweight. It's just an inaccurate measurement. And I know our doctors have told some of my families that they know that they're inaccurate, and they just kind of shrug it off. I've approached 3 different doctors. For a small town, there's not a lot of them, but they just don't seem to be concerned about using inaccurate information. And it's really hard not throw it in their face and be like, infant maternal health rates, you don't even get accurate measurements. Do you see the problem? It's like you just don't care. Obviously, that is not something that you would say, but I think it's really hard to even have those conversations because they're not listening. So for me, that is one of those really simple things that could be fixed. And I happen to know that their facility does have measuring boards. They just don't use them. So.
Oh, I was going to say, can we, put together a grant or something to be able to get the boards and then present them? But if they have them,
yeah,
and they're choosing not to use it, then that makes it extra challenging.
I find it very interesting that as a healthcare providers, that accuracy does not seem to be that important to them.
I did have a provider share in Multnomah County that one reason why they're using the paper method still is because of the time it takes to clean and wipe it down with every visit. So they were sharing that that was a barrier for them to use the length boards versus the paper, and that's why they continue to use paper, is time saving measures, which doesn't justify it, but it that's what the feedback I got, and I was like, interesting.
I wonder, gosh. I'm trying to think from a scientific perspective. One of the things that we do when I'm in ultrasound and I have a baby that is, falls in that, is I'm always going to go back and remeasure it. And I'm going to make sure that I confirm, because it falls into this, before I talk to this family about all the implications and the added testing and all of this, I'm going to go back and remeasure it. I almost wonder if there would be some way so that it wouldn't necessarily be every baby that would have this, but this subset, if it flags under this and this, then we get the actual board and we confirm it before we do XYZ, if there would be any more interest in that. So it's not every single baby, recognizing that there's going to be inaccuracies, but if it's going to change clinical management, if there would be any more of a willingness to be able to look at that. And if we looked at it from a statewide perspective, if there would be any more motivation as opposed to from a local, if there hasn't been a desire or an interest in that. Or if you just have stubborn providers, which we're certainly very guilty of being at times.
It is rather unfortunate. I do feel like we have problems with immunizations as well, with the providers not transporting them from alert into the chart. And so I keep having WIC families come in and be like, but you guys did my immunizations and my provider says I'm due for them, and they're upset with us. And it's like, dude, it's not on us. Your provider can fix this on your chart, but I can see you're totally caught up. So just don't worry about what your provider says, because you're really there. But we've talked to them about that numerous times as well. My husband's a pharmacist. He's talked to them because they've sent him people, and he's like, we've already done this. Why are they? And the older people get really confused, but so do some of the moms. Like,
yeah,
you're managing many kids with stuff, and they're very frustrated. But despite trying to say, hey, we see this problem, I feel like it is a very big challenge just to get the dialogue going and not just be brushed off on both topics.
Mm-hmm. Yeah. Yeah, I wonder if they would be open to any, we have our Oregon Perinatal Collaborative with some of our statewide missions and outreach that go to various areas. I wonder if this would be a topic that we could approach them with to see about trying to get buy-in around the state as we're also working on our other missions.
That would be lovely.
Okay. I think I have an upcoming meeting with some of those folks.
We have about 2 minutes left. So if there's any final questions or comments. Well, Dr. Marshall, I want to thank you so much for such a wonderful presentation and everyone for a great discussion and bringing really great questions forward. I think someone already said this in the chat, but you've given us a lot of really great information to reflect on and implement in the WIC clinics. So we really just appreciate your time and expertise.
Well, thank you for the invitation and for all of the incredible work that you are doing across the state. And again, if I can be a resource in any way, please let me know.
And I just have one final thing I'm going to share, just a quick survey link and QR code here. It's just regarding this particular meeting, so looking for feedback for the joint LAWN and breastfeeding coordinator meeting. Any feedback about today or any future topics that you might be interested in, just so that we're bringing topics and presenters to you, like Dr. Marshall, that we're excited about and really gets us excited to do the work that we do every day. So here's that QR code, and I put the link in the chat. So thanks everyone, and enjoy the rest of your Tuesday.